Hey guys, today we're going to talk about bone health for the gastroenterologist. Just a brief overview. So here's a case presentation. You are seeing a 14-year-old female in clinic. She has newly diagnosed Crohn's disease, and as you can tell from the growth chart, is complicated by malnutrition and growth delay, and additionally delayed puberty. So as we evaluate this patient and think about bone health, a few questions come to mind. One is this child's bone health at risk? And if so, what are the risk factors? Number two, when and if you order DEXA scan reports, how do you interpret those? And is it true that we can actually make a difference? Can we improve somebody's bone health? So just a few notes here. So what are the determinants of bone mass? Some of them are non-modifiable. So there are certain parts about this that you can't modify. That's genetics, gender, ethnicity. However, there are several parts of the determinants of bone mass, as you can see in this table, that can be modified, including nutrition, calcium, vitamin D intake, sodium, protein, soda, exercise, height, BMI, and hormonal status. And by far, the most important determinant of bone mass is the peak bone mass that's attained in childhood and adolescence. And therefore, it is thought that senile osteoporosis is actually a pediatric disease because it has roots in pediatrics. And our role as pediatric gastroenterologists in promoting bone health and giving our patients the best chance at having the highest possible peak bone mass is going to be very important. So the first question was, is the child's bone health at risk, and what are the risk factors? So the answer is yes. What are the risk factors? They include multiple ones. One is the malnutrition, protein-calorie malnutrition, the fact that there's delaying growth and puberty, inflammation, which can directly and indirectly impair the function of osteoblasts, steroid exposure, low muscle mass, which leads to low lean mass, and of course, hypovitaminosis D. There are possibly other factors, but these are the main ones. So the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, NASPGHAN, published these guidelines in 2011-2012, and in these guidelines, they recommended that for inflammatory bowel disease, a gastroenterologist should consider obtaining a DEXA scan in the following situations. As you can see, again, relating to growth delay, malnutrition with BMI Z-score of less than 2, pubertal delays, secondary or primary amenorrhea, severe inflammatory course, prolonged use of steroids, and history of clinically significant fractures, particularly vertebral fractures. Of note, the prolonged use of steroids is clearly defined in the paper. So let's talk a little bit about DEXA scan. DEXA, or dual energy X-ray absorptiometry, is a study where there are X-ray beams of different energy levels that go or traverse through the bones. And the bone absorbs these two energy levels, and also the soft tissue is absorbing them. So the absorption of the soft tissue is thus subtracted, and that gives you the bone mineral content. And then through calculation of surface area, you get the bone mineral density. And that should be BMD, and that's expressed as gram per centimeter square. So it's a two-dimensional and not a three-dimensional image. And in addition to measuring bone density, it actually measures indices of body composition, specifically lean mass and fat mass. So in adults, bone mineral density is reported as T-scores, meaning how does the adult compare to people who have already achieved peak bone mass development. So we cannot use that score for children because they have not yet achieved the peak bone mass. Whereas in children, we use Z-score, and we're familiar with Z-scores because we use them in growth charts and other things. So for pediatrics, we need to use Z-score. And the term for a Z-score that is less than -2 is osteopenia. It is very important to note that a fracture threshold cannot be determined by a DEXA scan alone. And you will see that caveat on multiple reports by the DEXA scan. They're able to give you what the bone looks like, but they're not going to be able to give you predictions on fracture thresholds because that occurs within the clinical context of the patient. One note again is the bone size makes a difference when you're getting a DEXA scan. So in this graph here, you have two bones of the same material density. And remember that density is going to be gram per cubic centimeters. What we're measuring is gram per centimeter square. So these bones have the similar density, but one is smaller. And as the attenuation from the DEXA scan comes through, the smaller bone is going to appear less dense. And therefore, that is one of the main issues that we have with DEXA scans, is it can underestimate the bone density for smaller children. And luckily, we have equations to correct for that. And we can have those in the references. However, in short individuals, the DEXA scan measurements need to be adjusted for the height of the patient. This is a quick cheat sheet. So if we're having a Z-score of -2 to +2, is considered usual. However, if risk factors are present, which is the vast majority of our patients who can be malnourished or have IBD, celiac disease, what have you, the Z-score then between -1 and -2 is considered low normal. Then we have -2 to -3, reduced bone mineral density, possibly contributing to increased risk of fracture. And then if it's less than -3, it would be significantly reduced and likely does increase fracture risk. So again, a couple of notes here. The term osteoporosis should not appear in a pediatric DEXA scan report because we don't know clinically significant fracture history. We don't know all the components of the patient's story. However, usually the term that's present is going to be low bone mineral content or low bone mineral density for chronologic age. That's the preferred term when BMC or BMD Z-score are less than or equal -2. This is an example of what a DEXA image would look like. It has the lumbar spine here, which is the standard place for measurement in children. The DEXA scan will give you measurements in other places, but the most data we have are on lumbar spines. And you can see where the technician draws this line around the vertebrae in order to make sure that all of the bones are included. And it plots it out here on a growth curve with Z-scores. Again, note that this is in data from the database that the DEXA, or what's called the Hologic software, has. And there are other databases that we can discuss more, but it's supported by the NIH and the Bone Mineral Density in Childhood study. Here's an image that represents percentage of body fat, which can also be scored on a growth chart, and that's coming from NHANES data. So can we improve bone health? The answer is yes. Sometimes we order a DEXA scan and we're not really sure if it's going to change the patient's management. I assure you that it can, and that if we take certain measurements, we are able to make positive improvements to a child's bone health. And those are things that we're focusing on anyway, but putting them in a bone context, I think, is very important. So we want to treat the inflammation as much as possible. We want to use steroid-sparing strategies, and we also want to improve nutrition, because the combination of this will improve lean mass, growth, and pubertal development. All of these will then, in turn, improve the bone health. What else can we do? So other interventions will be promoting physical activity, specifically weight-bearing physical activity. improving vitamin D status, and referring to a specialist, a bone health clinic, if a complication occurs, particularly compression fractures. Vertebral compression fractures are very concerning and almost always indicate a need for intervention by a bone specialist, for example, through the use of bisphosphonate types of medications. Here are some patient groups that can be at higher risk for bone disease, and you want to keep that in mind when you're seeing these patients and to consider obtaining DEXA scan or referral to bone clinic, depending on the case. That can be celiac disease. Although in pediatric patients, it is thought that gluten-free diet almost always normalizes bone density. However, it's always a consideration, particularly if one had a complicated course or has severe malnutrition. Inflammatory bowel disease, we talked about the criteria of when to get that in IBD. Intestinal failure, those on long-term parenteral nutrition, prolonged steroid exposure, any condition where you're going to have chronic inflammation, autoimmune hepatitis, and organ transplant recipients. So those are some of the high-risk categories, and there could be others. So just as a take-home point, a couple of things. Always think about bone health in your patients, again, because we are seeing the patients at or around the time of peak attainment of bone mass. So we really want to help them get to the highest possible peak mass. And then when in doubt, you can get a DEXA scan, get a dietary evaluation and the vitamin D level. And with appropriate management, nutrition resuscitation, bone health does in fact improve. And with that, I'm going to end the presentation. Thank you.